And if you are just joining us, this is our Samaritan Advantage Lunch and Learn seminar for Tuesday, August 17th. We're really happy to have you here with us. We're talking about the facts about bone health, and I'm really excited that I have my colleague, Dr. Holly Jo Hodges, here with me as well. And what we're going to do is just to make sure that all of you are aware that the presentation is being recorded. And there is a meeting chat feature to ask questions or to make comments at any time. And we will address those questions and comments at the very end of the presentations. And during the Q&A component at the end, you can even raise your hand by clicking on the little hand icon that is located at the right-hand top border. And then we can unmute you when we call your name if you would like to ask a question live. You can also ask the questions through the chat function. And because technology can be technology, we are all learning with this, and we will take it in stride and do the best that we can. So without further ado, we're going to turn it over to my colleague, Dr. Holly Jo Hodges, to talk about osteoporosis, that this is not only a woman's disease. Dr. Hodges, I'll let you do an intro about yourself as well prior to you taking over the conversation. Thank you.
All right, so I'm sharing my screen. Can everybody see that?
Yes.
Great. All right, thank you so much. So we're going to talk about osteoporosis and how this is not only a woman's disease. We're going to talk about how this impacts men as well. And this is our outline and what it is we're going to talk about today. And this is me. Just a little bit about me. I am a native Oregonian. I grew up kind of all over the state, but graduated from high school in Central Oregon out of Bend, and then went to Oregon State, right here in Corvallis, near and dear to my heart, and then traveled up the valley a little bit to Portland to go to Oregon Health Sciences University for medical school. And then when I returned after my family medicine residency, I set up shop as a solo primary care physician practicing full spectrum family medicine in Prineville, which is just outside of Bend. It's a small rural community where I practiced for 16 years and started my family, and then moved to Eugene, where I did urgent care for several more years, and then started working in this world of insurance. And I've been doing this now for the last 9 years after 19 years of clinical practice. And so I'm also a mom of 2 beautiful daughters, and I've been married as of this month to the same man for 30 years. So that's a little bit about me. And so let's start talking about osteoporosis. So in this diagram, we have normal bone on the left, and bone mass is how we measure the amount of the minerals that are in the bone. And those minerals are usually calcium and phosphorus that give us good, healthy bones. And bone mass measurements are used to diagnose osteoporosis and to see how well osteoporosis treatments are working, and to predict how likely someone is to have a fracture or a break in the bone in the near or even distant future. And so when we look at that bone mass, that's called bone mineral density, or BMD, and this was decided in 1994 by the World Health Organization that normals would be defined against 30-year-olds bone mass. And so when we're looking at those of us older, we're still being compared to a 30-year-old's peak and dense bone mass. So low bone mass, or osteopenia, is bone mass that is 10 to 25% below an average healthy 30-year-old adult. And then osteoporosis is further progressed, something like this third from the left diagram here, where the open spaces are getting bigger and the little trabecula or bridges of bone in between are getting thinner, and that is osteoporosis. And this can go on to be severe, like the diagram on the right, and this is a bone mass of less than 25, of greater than 25% lower than the average 30-year-old. So instead of 100% of the normal bone mass, there's only 75% or 3/4 or less, and that would be considered severe osteoporosis. So who does osteoporosis impact? By 2020, which would have been last year, there was 12.3 million individuals in the United States older than the age of 50 who had osteoporosis. And osteoporosis fractures, particularly hip fractures, can result in the inability or limitations in the ability to walk, chronic pain, and other disabilities, as well as loss of independence and decreased quality of life. 1/4 to 1/3 of patients who experience a hip fracture will die within the next year after that hip fracture, either from complications of the actual fracture and maybe the surgery or recovery of that fracture, and or the implications, the loss of independence and the decrease in quality of life, and other complications to other medical conditions that lead to death within a year of that fracture. And almost 3/4 of these osteoporotic or fractures related to osteoporosis occur among women, and women have a higher rate of osteoporosis than men at any given age. However, men who do experience a fracture related to osteoporosis have a much higher death rate related to that fracture than women do. And the prevalence of primary osteoporosis, or osteoporosis that we don't understand what the underlying cause is, in other words, there wasn't a clear other disease process going on, increases with age, and the amount of it differs by race or ethnicity. But what that means is that simply aging is a risk factor for osteoporosis without. And so how does osteoporosis impact men as compared to women? There's an estimated 1 to 2 million men in the United States who have osteoporosis, and an additional 8 to 13 million who have low bone mass. And again, as in women, men's risk of fracture increases with age. However, most fractures will occur 10 years later in men compared to women. In other words, women's highest incidence of fracture happens around the age of 60 and goes up every year. And then men starts at 70. So men's risk is 10 years older than women. And in the United States, just about 1 in 10 white men over the age of 50 will break a bone sometime in their lifetime due to osteoporosis. That's a lot. And a hip fracture is the most serious complication of osteoporosis. And again, compared with women, men are about 2 times as likely to die in the hospital after a hip fracture, or in that first year after that fracture, than women. So this is an important disease to consider for men. So the economic impact of osteoporosis is pretty huge. So while the good news is that all of us are living and expected to live longer, over the next 19 years, the number of Americans expected to be over the age of 65 is going to double. And in just a few years ago, there were more than 2 million fractures that were reported in the United States alone, with a total cost of around $17 billion. So if those rates stay the same, of the aging population continues to rise and the fractures continue along the same trend that they have been, by the year 2025, healthcare costs associated with fractures will reach over $25 billion a year. So as physicians, if we see that first fracture, we're always concerned that there's going to be a risk for a second fracture. And our job is to help you avoid the first one, and certainly we want to avoid the second one. So primary risk factors in men, again, simply being over the age of 70 is the first risk factor. And then in addition to being over the age of 70, you can be younger than 70 and have other risk factors that will increase the probability that you have osteoporosis. And those are low body weight. And so a body mass index of less than 20. So that's going to look like a 6 foot tall man who is 150 pounds or less. That's considered to be low body weight and increases your risk for osteoporosis. Weight loss of more than 10% of your body weight, not being physically active, corticosteroid or prednisone use, particularly if it's long, over 3 months time of continuous use is the cutoff where it starts to increase risk. And then androgen deprivation therapy, this would be anything that blocks testosterone. And this is typically used for the treatment of prostate cancer. And then a history of any particular person who has a previous what we call fragility fracture. What that is a non-traumatic fracture. In other words, you're doing something fairly normal. You're not involved in a car accident, for example. You step off of a curb, lose your balance, fall forward onto a wrist, and you break a forearm bone. That would be considered a fragility, or not really a non-traumatic ground level fall kind of a fracture. That increases your risk then of having osteoporosis, or maybe the first sign that you have osteoporosis. And spinal cord injury is also a risk for osteoporosis. And what all of these things kind of have in combination or in common is that there's not enough weight on the bones. Our bones react to pressure. So when you put weight on a bone, it reacts by creating and metabolizing stronger bones. So if we're not active, if we're not doing what we call weight-bearing exercises, if you have a spinal cord injury that impacts even your muscle tone and decreases that kind of pressure on the bones, that increases your risk of osteoporosis. So secondary causes of osteoporosis in men, again, these all kind of go back to those risk factors. Corticosteroids, so at least 5 milligrams of prednisone daily for more than 3 months. And again, prednisone is a steroid medication that people take. It's a really strong anti-inflammatory, typically used for conditions like rheumatologic conditions, some neurologic conditions, and pulmonary conditions, lung conditions like chronic obstructive pulmonary disease or asthma. A family history of one of those fragility fractures, if you have a brother or a sister or a parent who's had a low impact, say ground level fall, and they broke a forearm or a hip, that would be a risk, secondary causes. And then lifestyle. The two biggest lifestyle factors are smoking and high consumption of alcoholic drinks, more than 2 drinks a day. Both of those things interfere with the metabolism of our bone structure and increase osteoporosis. And then again, back to the testosterone levels, primary or secondary hypogonadism, which is low testosterone levels. And again, not only is it the hormone blocking for testosterone for the treatments for prostate cancer, but again, things like corticosteroids, prednisone, are known to decrease testosterone levels, and opioids or pain medications are also known to decrease levels of testosterone. So chronic opioids are also a risk or a cause for osteoporosis. And then vitamin D deficiencies and low calcium intake can also cause osteoporosis. So this can happen in just our normal diets if we aren't taking enough vitamin D or calcium in. And then the use of sunscreen is great and important, and we need to be sure we don't get sunburnt or get excessive sun exposure and melanoma or skin cancer. But by doing that, it blocks our body's ability to have the natural absorption of vitamin D from the sun. So those are some of the consequences of sunscreen. But again, we probably need to use the sunscreen to avoid melanoma as much as we can. So in about 4 of 10 cases of osteoporosis in men, we, the healthcare system, don't know what caused it, and we call that an idiopathic cause. In other words, we don't know why 4 out of 10 men develop osteoporosis. So how will you know that you have osteoporosis? So unfortunately, osteoporosis is what we would call a silent disease. Most people don't know that they have it until they have one of those non-traumatic fractures. And those fractures can then cause pain and disability and impact one's ability to function normally or as they had previously. The most common areas for fractures in men are going to be the hip, the vertebrae or the spine, those little discs in our spine that can collapse, the forearm or the humerus, which is the upper arm. And men with osteoporosis may also lose height as they age, which is an important reason to remember how tall you were when you graduated from high school or thereabouts, the age of 20, to know if you've been losing height over time, because that would be also another sign that you may have osteoporosis. So how can you prevent osteoporosis? Stop smoking. It would be a really good thing. Those are, and then having less than 2 alcoholic drinks a day for men, less than 1 for women. Again, those 2 things interfere with the metabolism and absorption of calcium and vitamin D in our systems, and impact and can hasten or speed along osteoporosis. So exercise daily, as little as 15 to 20 minutes a day of weight-bearing exercise, focusing on improving strength and balance. So fall prevention is the big reason, the big thing that we want to do to prevent hip fractures. And exercise can be really simple. It doesn't have to be joining the gym or going anywhere. I have always used to tell my patients, you know, when you unload the groceries, take out some cans of peas and just do some lifts with the cans above your head with your arms. That helps to keep the strength in your arms and the bones of your arms. And then just even carrying just those cans or anything that adds a few pounds of weight in your hands, leaving your hands down by your side, and walk around the house, walk around outside of the house. Those can be simple ways to get weight-bearing exercise without having to go anywhere or do anything. And you can do it for 10, 15, 20 minutes a day, pretty simply. I tell folks while you're sitting watching TV, you can use those cans up over your head on the commercials, and then every other commercial you can get up and walk around with them. So simple ways to get that amount of exercise in that can really help to improve your strength and improve your bone density and improve your balance to prevent falls. And then talk with your provider about calcium and vitamin D supplements. Those are available over the counter, and you can get those as well. And then eating good foods that are high in calcium. So milk products, leafy green vegetables, sardines, salmon, tofu, and almonds, all are great sources of calcium and vitamin D. And then again, you can get enough vitamin D from being in direct sunlight, at least in the summers in Oregon, for 10 to 15 minutes, 2 to 3 times a week. So, but again, you'd need to do that without the sunscreen blocking the absorption. So you'd have to be really careful. You don't want to get sunburnt. You don't want to increase your risk of melanoma. And again, Oregon winters are gray, as we know. And so my recommendation is that all men and women, for that matter, need calcium, particularly during the winter months, and vitamin D of 400 to 600 units a day. And calcium should be 1,200 milligrams daily. And you can get those usually in one pill that you can divide up once or twice a day. And that can really help to prevent these osteoporotic fractures. So screening and diagnosis, how is that done? You have to get a bone density scan. It's the only test that will be able to diagnose osteoporosis. The lower your bone density, the greater risk you are at breaking a bone. And the bone density test can help to tell you and your provider if you have weak bones or you already have osteoporosis, maybe, and hopefully before you break a bone, because that can be unfortunate. It can predict your chance of breaking a bone in the future and help direct treatments. It'll see if your bone density is improving. So maybe if you have low bone density and you want to try some of these other lifestyle adjustments, taking the vitamin D and the calcium and doing those exercises, and then you want to recheck it to see if things are getting better or worse. And again, you can use the DEXA scan. That's what these bone scans are called, a DEXA scan. You find out if your osteoporosis medication, if you're taking one, is working. And again, if your first sign is a fracture, one of those non-traumatic fragility fractures, then you'd want to have a DEXA scan or bone scan to know if you do have osteoporosis. And again, so based on those recommendations, when would a bone density test be needed? So the National Osteoporosis Foundation recommends that you get a screening test if you're a woman over the age of 65, if you're a man 70 or older. If you're over 50 and you break a bone, you should get a DEXA scan just to make sure that you don't have osteoporosis. And then if you're a postmenopausal woman under the age of 65 with risk factors, you should get a DEXA scan. And the same thing if you're a man over the age of 50 and younger than 70 with any of those other risk factors we've talked about, you should get a DEXA scan. And the photo here is a picture of what a DEXA scan looks like. They focus on the hip, the bone in the hip here. The neck is where the fracture usually happens. So that's where we want to measure the bone density. And then they'll usually look at the spine, a section of the spine as well. And it doesn't matter where you get the DEXA scan, you should be able to get them any place that offers them. And over time, they should be comparable to be able to look at the old ones to see if your bone density is getting better or worse. So other reasons that you might want to get a bone density test, if you get an x-ray of your spine for some other reason and it shows a break that you maybe didn't know you had, or if it shows bone loss, sometimes you can see the early mild osteopenia bone loss in an x-ray of your spine. If you have back pain and there's question of whether or not you have one of those vertebral or spinal column fractures in those the little spaces that put together our spine, if those are collapsing down, that would be a reason to get a DEXA scan. And if you lose a half an inch or more in height over 1 year, or if your total height from the tallest height that you know you had, usually around your age 20, if you're now more than 1.5 inches less than that, you should get a DEXA scan. And this can be one of the first signs, particularly in men, is this height loss that tells us that they are developing osteoporosis. So that's why it's really important, even though I know sometimes it's a hassle to get your height measured at the doctor's office. But the next time you go in to see your primary care provider, be sure to ask them to take your height and ask them to tell you how it compares to some of your previous heights, so that you and your provider can understand if you're losing height and whether or not maybe a DEXA scan would be important for you. So treatments, and again, you should talk with your provider and take into consideration your risk factors, your bone density scan, your height, and whether or not you're losing height, and some other, sometimes there needs to be some lab work done to look for metabolic or absorption issues. And taking all those things into consideration, then decide if treatment is indicated. And again, the first place to start would be calcium and vitamin D. And calcium alone or in combination with vitamin D can reduce your fracture risk by up to 12% in men and women over the age of 50. So then if someone does have a diagnosis of osteoporosis, then we move on to a class of drugs that, and we should take calcium and vitamin D as well, but you would also then take bisphosphonates. And this is a medication such as alendronate, which is called Fosamax, and that's a weekly pill. Then there's risindronate, which is Actonel, which is a weekly or monthly pill. Abandronate or Boniva, which is a monthly pill, or a quarterly, which would be every 3 months, intravenous infusion through a line into usually your arm. And then zoledronic acid or Reclast is an annual IV infusion through that needle into your arm. And all of those work the same way to stop bone breakdown and hopefully then stop and treat your osteoporosis. So then there's another medication called denosumab, which is given through injections under the skin every 6 months. And it's a different kind of medication that people can take if they can't tolerate bisphosphonates. The biggest side effect with the bisphosphonates is typically gastroesophageal reflux or heartburn. And some people can't take those medications, so then they would move on to this one. It's also good for people who have kidney problems or reduced kidney function. And then if those medications over time aren't working, or if somebody has to take chronic steroid medications, prednisone for other medical problems that they have, and so they know they're never going to be able to stop the prednisone, then they may need to move on to these bone building medications, which are parathyroid hormone medications. And these include, these are harder for me to say, teriparatide, which is Forteo, or the abaloparatide, which is Timos. And then the very newest is this romosumab, or Evenity, and that one is actually not approved in the US quite yet. But these medications are medications that you can only take as an IV infusion, and these are medications that you can only take for 12 to 24 months at a time. Bisphosphonates you can take for 5 to 10 years at a time if they're working for you. So again, treatment, things that are easier than medications and will have good impacts on the rest of your conditions and your health are going to be exercise. Again, we talked about weight-bearing physical exercises, trying to improve your balance, your posture, strengthening your bones, and reducing your risk of fractures. And the more fit you are as you age, the less likely you are to fall and break a bone. Your good nutrition, getting enough calcium and vitamin D, stop smoking, and limit your alcohol. Both of those things speed up the bone loss and osteoporosis. So we want to introduce those changes. And again, the whole thing is about fall prevention practices. So if you've had an illness, or for some reason you may have had a period of inactivity where you were unable to exercise or do your normal movements, then you might get some physical therapy and they'll help you work on gait training and balance. You want to minimize the use of any psychotropic medications. Psychotropic medications are anything that interfere with our brain's ability to think, and it might make us sleepy or decrease our coordination. So the biggest thing to try to avoid are sleep medications, medications that muscle relaxers, and pain medications or opioid medications are all tend to make us sleepy, decrease our coordination, and increase the risk of falls. And then the other thing to think about is walking around your house and maybe having a family member help with this to remove or reduce any tripping or falling hazards in your house. The first thing that always comes to mind are loose rugs or rugs on top of other rugs where it might catch your toe as you're walking and just tip you over. And the other thing we need to be conscious about is our pets. And I don't think anybody should ever get rid of a pet for these reasons, but you'd want to make sure that your pets are well trained and they're getting all the exercise they need so that they don't get tangled up in your feet and cause you to tip over. There's lots of benefits to pets that we want to be sure to utilize, but if you have young pets, you want to be sure they're getting all the exercise they need, either with you taking them exercise and getting them that, or hiring your grandchildren or the kids next door to make sure that those pets are well exercised and don't get tangled up with us, because you don't want to fall and break a hip. So when should you see your provider and ask about getting a screening DEXA scan? If you're a man over the age of 70, if you're a man that's younger than that and you have or develop known risk factors, and again, we'll just review, if you have or you've recently in the last 6 months had one of those fragility or low impact, ground level fall fractures of a wrist or a hip, you should have a DEXA scan. If you're currently taking or you recently started taking long-term chronic steroid medications for more than 3 months, you should get a DEXA scan. And if you're currently being treated with for prostate cancer with testosterone blocking hormones, that would be another risk factor. You have low body weight or recent weight loss of more than 10%, or any of the height loss we talked about, you should have a DEXA scan. And if you've had a recent period of, or even a long period of physical inactivity, then you should definitely talk to your physician about getting a DEXA bone scan and determining further treatment modalities. So this is the current, the young person's spine on the left here, and then as we develop more curvatures as the bones are collapsing here from osteoporosis, and then in the end on the far right here, this is a highly curved spine with severe osteoporosis that we want to try to avoid. So I will stop sharing my screen here. These are my references for the work that we did here, and I'll move to getting back to Dr. Ewanchyna. And I think we're going to answer questions all at the end. Is that right?
We are. We're going to do the next presentation. And for people that want to ask questions, you can use the chat feature and type in your questions, or you can raise your hand and we will call on you and unmute you to ask your question. But I did have one, Dr. Hodges, just to ask before we move into the osteoarthritis. So I'm sure many of our members have seen parked in parking lots, large mobile units that are advertising heel bone scans. And is it preferable to do a heel bone scan or more preferable to do the standardized DEXA scans looking at the hip and the spine?
Thank you for that question. That was great. I should have brought that up. Yeah, those can be a great screening device, and sometimes they can identify osteoporosis. But if those are abnormal, then generally it's a pretty advanced stage of osteoporosis. They're definitely not as good at identifying osteoporosis as a full standardized DEXA scan. So we would encourage that certainly if there was anything wrong on one of those screens, you'd need to see your provider and get a DEXA scan. But if you really have any of those risk factors or at all concerned, you should see your provider and get a true DEXA scan to get an accurate reading.
Great, I appreciate that.
Yeah.
So thank you very much for that presentation. And again, to our audience, we'll have time for question and answer for both osteoporosis and osteoarthritis. For those that have not met me before, I am a family doctor like Dr. Hodges. And the thing you got to remember about family doctors is we chose family medicine. It wasn't what was left over. This was a calling for many of us that are drawn to primary care to really form those relationships with the patients that we serve. And really, really excited that we have two family physicians, actually three family physicians within Samaritan Advantage Health Plans. It's Dr. Kaiser, Dr. Hodges, and myself. But I was trained in Canada and worked in Canada at a military base for 3 years, looking after the dependents and military personnel of both the Canadian Army and the British Army. And then my wife and I wanted to escape the prairie snow, so we have been in Oregon for the last 23 years and loving every bit of what Oregon can bring to us. We just got back over the weekend from a family trip back to Canada to see our family members, as we haven't been able to see them for the last couple of years due to COVID. So that was a real pleasure for us to be able to hug our vaccinated parents as we were all vaccinated as well. But we're going to talk about osteoarthritis today, and I really wanted to talk about some of the myths that maybe we have heard about what arthritis is and isn't, and try to clarify that for all of you today. So we'll move to the next slide. And a little bit about osteoarthritis in general is that it affects 21 million Americans. Many people are surprised to see that many individuals that are affected by arthritis or osteoarthritis. But osteo, meaning bone, is the most common form of arthritis. And it's interesting to see that there's about $86 billion a year. That's annually of those 21 million Americans that have expenditures in medical care and also indirect expenses, people that may not be able to work full time due to their osteoarthritis that is limiting them, also lost wages and production. So it's a very costly disease to treat, and we can do a lot with prevention. So the next slide will show us that overall, there are myths about what joint pain is and what arthritis is. And if we could advance to the next slide, Mary, it will show us that these are the resources, very skilled and noted clinicians in the field of arthritis across our nation. They took a lot of our recommendations from. So thank you to Dr. Husney, Dr. McGrory, and Dr. Chewin. But the first myth about osteoarthritis, we hear, well, it's just wear and tear. I don't have to worry about it. But the fact about osteoarthritis is that we really don't know a lot about the cause of osteoarthritis. And if we go back to that next slide, the following slide, there we go, thank you. And we do know that it is a little bit more than just mechanical wear and tear. We know that there are genetic factors that play a role in osteoarthritis. Mechanical factors like injuries to the joints also play a role. And then we also understand there are biochemical factors. And then we also understand that besides the mechanical forces that occur with joint damage, the cartilage that is in our joints is starting to be destroyed by these enzymes called metalloproteinases. And these slowly destroy the interior framework of the cartilage. That's our shock absorbers. But we're still trying to understand the role of genetics in osteoarthritis. And we do see that there are family tendencies for osteoarthritis. It can run in families, and also we know that in certain patients that have a genetic defect of their cartilage, they might be more prone to developing osteoarthritis as well. So very important to recognize it's not just wear and tear. This next slide here will show us that the next myth, myth 2, is that all joint pain is arthritis. And we do know that other conditions can cause joint pain. Things like tendinitis, which is an inflammation of the tendon, the bursa, so in our knee, in our elbows, in our hips, there are these different things called bursas. And the soft tissue injuries can also cause joint pain as well. And there are a lot of structures around the knee itself, around the joints, that are that can cause the pain and swelling and can mimic this joint pain as well. So continuing to the next slide, we'll see the other fact about joint pain and osteoarthritis is that osteoarthritis is the most common type of arthritis for anybody that's over the age of 50 years old. And some of these symptoms that we see for osteoarthritis is swelling, pain, and difficulty moving your joints. And we usually see osteoarthritis can commonly start in your 50s, can get worse over time, but also understanding there's other structures around the joints that can cause that pain in the same areas and can mimic that joint pain. So not all joint pain is osteoarthritis. Next slide. The next myth, and we've heard a lot about this living in rainy Oregon, that rain and damp weather will worsen arthritis. And the fact is, some may feel a twinge in the knee that they say, I know that rain is coming. It's going to be happening soon because I can feel it in my bones. And that's a lot of anecdotal statements that we can see, but there isn't any hard scientific evidence that the dampness or increased humidity really intensifies or makes worse arthritis itself. The next slide will show the next myth, myth number 4, that osteoarthritis is potentially reversible. And the fact is, there's really, really little scientific evidence of any treatment approaches that halt the progression of the disease. And there isn't any scientific evidence that the disease process, once started, can be reversed and go back to healthy joints or healthy lining of the joints where the cartilage is laid down. The fact as well is that limiting the excessive impact loading of joints may slow disease progression, may also reduce pain, and thus weight control and exercise is really, really important in slowing the progression of the disease. About the next myth, myth 5. And this is the myth that we have to take it easy with exercise if arthritis acts up. And the fact about exercise is that regular exercise actually helps arthritis. The theory that motion is lotion. But understanding that arthritic joints also will need a short period of rest and then a gradual return to that exercise that you're doing. So make sure you don't exercise for hours on end, but keep doing moderate amounts of exercise, give your ability to have some rest of your joints, and then take up some exercise again. Trying to limit that excessive force, though, that is occurring on the joints. But also maintaining strength, strengthening exercises of the legs and the arms, very, very important for reduction of arthritis. And the movement in the joints is encouraged when you do have an arthritis, because if we don't move our joints, they tend to stiffen up on us, and they actually make the pain associated with arthritis worse. Here is a little plug for physical therapists, occupational therapists, and exercise physiologists. They are not there just to treat and diagnose conditions of strains, etc., but they're really there to help give support and exercise recommendations for individuals that have osteoarthritis as well. And it's not known widely that in the state of Oregon, you do not need a doctor's referral to see a physical therapist. You can actually make those referrals just on your own. Now, sometimes that physical therapy clinic may like a referral from a physician, but just know that that isn't required here in the state of Oregon. So the next myth that we're going to talk about is myth 6 on the next slide. And this is where ice is less helpful than heat for sore joints. We'll see that the fact about ice or heat is that both are actually good and useful for arthritis. And we always say, do what makes you feel the best for any of your joint discomfort. For some people, you like getting a better reduction of pain and swelling from cold. Other people like using heat. And Dr. Husney stated that, applying ice at nighttime can relieve and ease the joint inflammation that comes up from doing your daily activities. But then maybe applying heat first thing in the morning can start to relax those muscles, get that blood flow going to your muscles, and that can start to help with moving those stiff joints that arise through the nighttime. The next myth, myth 6, continued on the next slide, is that another good tip, if you do apply ice to any of your sore, swollen joints, do an ice pack for about 20 minutes at a time. But if you don't have an ice pack, get some frozen peas, vegetables from the freezer, put maybe a tea towel around it, put that on your joint, or you could even utilize some ice cubes, put that into a plastic baggie and use your home ice pack for that. The next slide will show myth 6 continued, that a heating pad really does help a lot for sore joints as well. And if you don't have a heating pad available, some people like to put a slightly damp washcloth or towel into the microwave for about 15 seconds. If it's too hot when you first touch it, let it cool just slightly, but then put that on your affected joints to help soothe them or the affected muscles. And also, warm baths, warm showers for pain relief can really do some wonders. The next myth we're going to talk about is on the next slide, and we're going to talk about some of the supplements we've heard about, like glucosamine. And the myth is that supplements like glucosamine can benefit every single person that has arthritis. The fact about glucosamine that we've seen is that it can help with a subset of people that have osteoarthritis pain. Glucosamine does not reverse the arthritis that is there. It does not get your joints back to that of a 20-year-old. But in some people, it can help with the pain of the osteoarthritis itself. And what we usually say, if you go to the next slide, is that, take it for a period of 3 months or so to just see if this makes a difference or not. And if you do see that it made a difference with a reduction of pain, continue to use it. If you didn't see that there was much of a reduction of pain in that 3-month time period, then don't waste your money. Look for other alternatives and options. The next myth we're going to talk about is on the next slide, and it is the myth of cortisone shots for everybody. We sometimes think that we should go to the orthopedic surgeon or a family physician, internal medicine physician, and get cortisone shots in each and every joint that has arthritis. But the fact about cortisone shots is that there's a lack of evidence that states that they work for the long term. Of course, we know that it can help people in the short-term reduction of inflammation from osteoarthritis or other forms of arthritis in your joints, but it's really a lack of evidence that shows they do a benefit over the long term. And there are some concerns with cortisone, which is a steroid, of getting too many of these injections as well. In fact, we know that in about 7 to 8% of people that get steroid injections, it actually accelerates or makes worse their arthritis beyond what we would usually expect to see. So a word of caution with that. Also, with cortisone shots, we see that unusual fractures can occur, and it's low. It's about 1% of people, but it is a risk of cortisone shots. Also, bone damage in about 1% of people, something called osteonecrosis, where it's eating away parts of that bone, can occur. Again, low rates of concern there, but it's about 1% of people. And also acknowledging that if you are diabetic, you should be using steroids with caution because you can have a temporary increase in your blood sugars. Also, cortisone shots in your joints, there can be temporary bleeding, infection in the joint that can also occur because you're puncturing through the skin and into a joint space, something that really shouldn't be there. So just a word of caution, cortisone shots can be helpful for some for acute arthritis, but the jury is really out in what they do for the long term. And this is why there's been a change in the amount of our cortisone shots have been given for certain joints and over an annual time period. The next slide, running makes all arthritis worse. And the fact is that we find that medical research has actually shown that running doesn't cause or aggravate any of the degenerative bone disease that is there. And the fact from the medical experts, they recommend that arthritis sufferers stay as active as possible. Exercise, which includes recreational running, helps us maintain a healthy weight, promotes joint flexibility, a range of movement of your different joints, and it strengthens the muscles around your joints. So if you are a runner, please continue because not only is it good for your heart and aerobic activity, but it is good in the long term for prevention of arthritis that is worsening. Now, if you do have acute episodes of arthritis, I would say start with some low impact exercises first, like swimming, doing aerobics in the pool, doing some walking, doing some cycling, and always consult your doctor before you begin or consult your physical therapist. The next slide. We'll continue talking about lifestyle modifications and some of that self-care that we've already talked about. That is maintaining a healthy weight or losing weight if you are overweight. Also staying active. And if we could move to that next slide, thank you. But balancing activity with appropriate episodes of rest. We also know that it's important to do a diet that's rich in nutrients, maintaining a healthy sleep routine. Smoking cessation will help with osteoporosis, as we heard from Dr. Hodges' seminar, and also can help with some of the pain associated with osteoarthritis. So if you are a smoker, another reason to look at discontinuing that. And then also practicing good body mechanics, sitting up straight, doing proper posture with standing, good lifting techniques, using our legs instead of our back to do proper lifting. And I think that is wrapping up the myths and the education around osteoarthritis. So we now have time to open it up to anybody that might have questions about either osteoporosis, osteopenia, bone health, anything related to osteoarthritis. And just as a final statement too, before we entertain questions, that a final email will be sent to all participants today in a couple of weeks from now. And in that email will be a recording of this seminar that you can watch later on. There's also a survey for you to let us know how things went with this seminar today, and also an opportunity to give us feedback for future topics that you might want to hear about. Also, we did have a registered dietitian by the name of Sarah Thomas. She unfortunately could not be with us today, but she did provide some helpful hints from a dietitian's perspective on what we can do for bone health. So we'll have that listed for you as well. And as a thank you to you, we'll of course like to see people in person and do a lunch with you if we could, but we will have a lunch gift certificate that's included in that email that is sent out to you as well. So any questions that might be from the group today?
I think there was one, Dr. Ewanchyna, that asked, can you help to do a prescription for calcium and vitamin D? And if you'd like, I can go ahead and answer that.
Yeah, go ahead.
Yeah, that would be that you should absolutely follow up with your primary care provider to get that prescription, and they can absolutely be prescribed if they're appropriate. But the reason that you should see your primary care provider is to be sure that you're getting the right dose for your risk factors or problems, and that there is that you don't have any underlying kidney disease or any contraindications to getting those medications. But the short answer would be that no, Dr. Ewanchyna nor I are not able to be able to write prescriptions from this class.
There was also a question, how about dietitian advice or class, please? And we're going to be sending out those notes that the dietitian was going to go through today for you to review. And feel free, if you did have questions about that dietitian advice that we do send out to you, there's an opportunity in the survey to add extra information there. Exercises that we would recommend for balance. Yeah, that's a really, really good question. And especially first thing in the morning when we wake up, our balance can be off. And one of the things to ensure that we're not going to be at risk of falls in doing these balance exercises is to make sure that you're holding on safely to something that is around in your room when you first wake up. So many people like to incorporate, standing on one leg at a time while you're holding onto an object for some support so you don't fall, as a way to kind of increase that balance. Other people will say, sit on the edge of a chair and close their eyes and slowly move around their body just from their waist upwards, like I'm doing right now, in a way to just kind of stimulate that balance center in the brain to learn those different positions that our body is going through at any given time. And then balancing exercises as well. Physical therapists will have many other balance exercises that they can be recommended to you. Many people I'm aware of have started to take up Pilates or yoga, and these have also been shown to improve people's balance. Dr. Hodges put in the chat that eating foods that are high in calcium, like milk, dairy products, leafy green vegetables, sardines, salmon, tofu, almonds, all very important for getting that increased calcium support as well. Sylvie had asked the question, why would men likely die after a hip fracture? And the thing that I'm thinking about, and Dr. Hodges weigh in here, but because men right now are more at risk of heart disease versus women, that after a hip fracture, when they're more sedentary, that there might be more prone to having an adverse heart event or adverse stroke, just because men are more likely to have that compared to women. But any other thoughts there as to why men might die more frequently after a hip fracture versus women?
Yeah, I actually had pondered that myself and tried to do a little quick research on that, and a lot of it really is still unknown. But the preponderance of the thought process is that yes, they have more complicated and advanced underlying chronic diseases that don't do so well with inactivity that requires after you have a hip fracture, the lying in bed and reducing that activity levels.
Right.
But a lot of it's still unknown.
Judy had asked the group, how often should we get a bone scan?
Oh, that's also a really good question that doesn't have a lot of good answers. If you are a man who's 70 or a woman who's 65 and you get a DEXA scan and your bone density is normal, you pretty much have 10 years before you need another one, unless you develop any of those other risk factors. And so it's really something that, again, you kind of have to take it into consideration with your provider and your risk factors and your other medical conditions. But generally, unless you're taking medications to improve osteoporosis, we don't recommend a DEXA scan any more frequently than 2 years at the very most frequent, and that's only if interventions are being done. So generally every 3 to 5 years, but you should talk to your provider to be sure that's right for you.
Right. And Patty had put in the chat about prescription coverage for calcium or vitamin D or over the counter. And I think in your slides, you had USP, that as long as it's a reputable source or USP verified, that the over the counter should be just fine.
Yes, I agree. I take over the counter.
Yeah. And you know, there have been some studies though about many supplements now that it may not be exactly what you think in terms of dosages or other things that are put in the vitamin supplements, because there isn't a lot of regulation about that. So my advice is always making sure you buy it from a reputable source that's been around for many, many years, versus something that might be a off-brand or a brand new brand of a vitamin supplement that you're just not aware of. So stick with the brand that has a good name recognition behind it, and usually people will be better off. Great. Well, with that, thank you so much to our Advantage members for joining us for this Lunch and Learn seminar. Another reminder that in a couple of weeks from now, you all will be getting by email a copy of the webinar that was taped. Also a survey so you can let us know how we did. Also the opportunity to ask some other clarifying questions or comments, and topics for future Lunch and Learns. And then also we'll be including the dietitian's handouts from Sarah Thomas, and a lunch gift certificate will be included. And I wanted to make sure we all gave kudos to Shannon Coleman. Many of you have met Shannon over the years when we were meeting in person, and Shannon has been integral to our team in helping produce our Advantage Lunch and Learns, and she is going to be leaving our health plan to go and become a nurse at Albany General Hospital. So we're happy Shannon is still staying in the Samaritan family, but very unhappy that she's leaving the health plan family. So thank you, Shannon, for everything that you've done for us in the past and for today's conversation. And with that, I bid you farewell. Thank you, Dr. Hodges, for assisting me and being my colleague today. And take care of yourselves. Be safe. Thanks for attending.
Bye now. Take care.